day. Namaste, Barkam, and hearty welcome once again to all our dignitaries, guests, delegates, partners. With great joy and immense exultation, I feel privileged to welcome one and all. This is Chandni Sehgal, your host for the day, and I feel privileged to be part of this wonderful event. A truly blissful morning indeed, as once again we have come together, distinguished guests who are the members of Executive Board, most prized delegates and valued audience. As overwhelming elation sweeps us, we have gathered today to acknowledge the most talented pool of vibrant people. In our pleasure to welcome you all to the NICE Conference Live 2023 on 29th April 2023. This is the third and the last leg of our event here today. This meeting has been featuring a comprehensive 3-day program with eminent speakers from across the world who will deliver high-level scientific content, perform live and recorded cases and workshops. So without further ado, let's gear up and get ready for this meeting to be most stimulating and meaningful. So to take the first session of the day forward, I would be requesting the humble presence of our moderators now. Let's welcome them with a round of applause. Dr. Dimitri Slopes and Dr. Gaurav Goel. Let's welcome our moderators here on the stage with a round of applause, followed by our panelists, Dr. Matthew Chirin, Dr. Batok Siora, Dr. Mark Rebo, Dr. Shyam Kumar N. Keshava, and last but not the least, Dr. Stefan Shaw. So it's going to be quite an interesting and energetic session henceforth. So I would request the moderators to take the lead on for the same. Thank you.
Shyam, please join us. Good morning, and it's good to see all of you so early in the morning here. Our live cases are all set up and ready, and Dr. Matthew Cherin is here. Okay, so maybe we can ask him to join. Dr. Dimitris, can you hear us? So my fellow moderator is in US, so he's going to coordinate remotely with me. And just to remind you, a few of you may have joined today. So do take part in the polling. Can we have the QR codes to show? And the Q&A session. So you can scan the code and just go and type in, and I'll try to go along and ask our panelists for answer. And can I also ask Mohammed Shafiqul Islam to please join us on the panel, please? Thank you. Dr. Dimitris, can you hear us now?
I can hear you.
Yes, and I know it's a late evening for you, but it's a very good morning for us. And thank you for doing this for us. So you are moderating along with me, and we have 2 live cases. So without wasting time, we're going to move first to a very exciting case from Dr. Suresh Girgani. Anshu is going to present that case for us.
So this is a 21-year-old gentleman who presented with seizure disorder. So you can see on an MRI in the parietal region there is a cystic lesion using a double lumen balloon plus onyx and coil. Let's see what he is going to do with this case.
Yeah, so it's going to be exciting. I think we saw some good pressure cooker technique by Dr. Matthew Cherian on day 1. You saw how Tariq tried to do a pacing and use that to the advantage to treat fistula, and now we're going to see how we can do this with balloon. So can we go to Hyderabad now? Hi, good morning, Suresh. Can you hear us? Audio, please.
Can you hear me? Hello?
Yes, Dr. Girgani. Yes, we can hear you.
Good morning, sir.
We
I
can't.
thank for giving me this opportunity, and we just started the case.
We can't see you very well. You are hidden behind the screen.
We asked them to relocate the camera once again.
Okay, all right. No, we just
No,
want to see you bright up in the morning. Thank you so much
no,
to be up in the morning so early and starting this. Yes,
no,
please
no
go ahead.
problem. So, so now we have placed the guidings in both ICs. Bilateral IC are a bit tortuous in the cervical segment, so we have used this neuron and neuron MAC system.
Can we
And the
show?
plan is,
We can't see the screen. So can you show us the screen? We can't see the angiography screens. It's just in the inset. Maybe they can enlarge the screen and minimize. Yeah, that's perfect.
yeah.
Yeah, go ahead.
So the AC, as you can see, the plan is now first to deal with the largest communication, the fiscalous communication, and then to go for the nidus. So it has got two components. The nidus component is better filling on the right IC and UC, whereas the fiscalous component is filling on both right IC as well as left IC. So the plan is to first close the largest feeder from the AC, and then tackle the nidus component from the AC as well as MCA using simultaneous McArthur cannulation. So that is the plan. So technical difficulty, what I am anticipating is one, the ACA caliber just before the fistula is quite kind of trumpet shape. So once we place the balloon may occlude or may not wedge it. So that is one thing. If not wedging, then using balloon it may not be feasible. So the plan is to place two catheters. One is balloon from the left side, and from right side we are trying to pass detachable catheters only. So if the balloon is working at fistula side, then well and good. Otherwise, I'll try to pull the balloon back into the A2 segment where the caliber is a bit smaller. And then I'll try to inflate there, and the detachable catheter more distally placed, we'll place the liquid embolic. EVOH we are trying to do.
Okay.
So are there any views about the case or any other ideas that the audience can give, moderators can provide?
So, okay, let me start with Dimitris. Your thoughts on the case?
Yeah, I was considering to place some coils on the venous pouch before, either from arterial or venous, if that would help to slow down the flow. That may be a consideration to have up front, put some coils on the venous side, as of course you have your balloons in position, but you wouldn't rely only on that to stop the flow, but also have some resistance on the venous pouch. Is that a consideration or no?
So I don't think Suresh is planning to put coils here. He's primarily relying on the balloon for the to slow down the flow and create a pressure cooker there.
Yeah. Many times we've seen the embolic go very fast through here, so it's probably a high flow fistula, but that would be my concern. That's all.
Yeah. Sham, your thoughts?
I think the plan of balloon.
A bit louder. I don't. Yeah.
I think the plan of keeping a balloon proximally looks. I think should work well. What they've already planned works well.
So yeah, tell us, Suresh, what you have done so far. Is your
Guiding some players, but there is some kink over here.
Yeah, there's some kinks in the tonsillar loop.
So sorry, I missed out. Which balloon is this?
This is Eclipse double lumen.
612?
Yeah, 612. 612. I think we need to change the guide.
Okay. So what we're gonna do, Suresh? I can see you have to. Your guiding is kinked there. We can see the guiding is completely kinked there, and you are not able to pass the balloon. So while you change your guiding and you park your balloon across, we're gonna quickly move to Chennai, and then we're gonna come back to you.
Yeah, sure, sir. Thank you.
All right. So can we show Chennai's case? Maybe you can just put it up here. I can show.
Something else. What you're giving. Okay. Naviana Sophia on the Sophia 620.
So, as he's preparing, we move on to Chennai now. So, Sri is doing this exciting case of a 61-year-old lady. She had a trivial injury by the husk, and there was some swelling and redness of the left eye, and with a pulsatile proptosis and chemosis. That's the eye.
So I think you got an indirect CCF, right?
Yes,
And
Dr. Matthew Charan. So, good morning, sir. We were looking for you.
so, sorry. So, do we have a diagnostic angio? Do you have an axis?
So yes, we go to the
Okay,
right there.
let's have a look. It's going across one cavernous to the other cavernous.
Yes.
Is there a petrosal sinus filling? I don't think we see anything out here.
No, I think both petrosal sinuses are not patent.
Yeah, so the main outflow is from the ophthalmic on the left side.
Yeah.
Is there a facial vein that you see?
Yes, there is a facial vein here. There is a facial vein here.
So one of the things we have been doing very frequently now is we access the facial vein. We have done it either percutaneously or by going transfemorally across the jugular vein, and we find that a pretty easy access. We stopped doing percute on the superior ophthalmic vein. Gaurav, have you tried that? I mean, we find that with the new generation micros pretty easy, you know.
So our experience is like we almost always have been able to access if there is a good connection. Only once I had to go for a cut down where we just couldn't, so we had to do a direct cut down and go. So I think what Sri is planning here is to go through this facial vein and try to close this indirect CCF. And as I said, we are trying to complement. So on day one, we see a type 1 direct fistula with a balloon and liquid embolic, and this is the other route to come through. So over to Chennai now.
Actually, this cut down is quite a messy affair, you know.
Sorry.
Cut down. So it's Apollo all over.
Hello.
Yeah, yes, sir, please. Mike, please.
Hi, Gaurav. Good morning.
Hi, Sri. Good morning. Dr. Karapurkar wants to add something. Just hold on. Yeah.
Sure.
Access from below is not often very difficult, as you said.
Yeah, we have found it very standard now that we access from below, enter the facial vein at the point of the junction. Yeah. We use a catheter like a Bernstein to hook it and then take a micro from that point.
So we are talking about the direct puncture. So I had done 4 of these, and 4 of them are uneventful. Of course, this was many years ago. One patient I remember we punctured, and somehow we counter-punctured. And
It's a mess, yeah.
this was a high flow. The eyeball literally started, popping out. And we were doing it at a local. Patient went into bradycardia, and we had no choice but to occlude the artery. So we just this was many years ago. Those days we were using balloons for all CCS. So there was no other access. That was
No, but I think what you're talking is a direct CCF.
Yeah.
Yeah. But
So
that,
we've stopped doing, since then I have not done a direct puncture. But this was also with a cut down, but even then when you're trying to put the sheath in, somehow we counter puncture.
But as Dr. Matthew Charan is pointing out, it may be different in this because it's an indirect, so we do not
indirect, so
expect
flow
that
is
to be
much
a very.
slower.
So flow will be much slow. That's
so
true.
that kind of problem. But I'm surprised why you went direct, because in CCF the petrosal sinuses are all open, you know.
This was many years ago. This was before the days of the
No,
wire.
but Dr. Karapur, even many years ago, I don't think the petrosal sinus would have shut up, no?
I know, but for the balloons that we had, the balloons,
Okay.
there was no access.
Sri, can you tell us what's happening in your center?
Yeah, let's just go through. I'll just run through the angio images that we have done. The previous angio
We
that I
can't
showed
see
you
your
was
screen.
from an
We have
outside
to,
institution. We didn't have much of information with that.
Sri, we need to see your screen. We are seeing you, not your screens.
1 minute. Yeah. Satish.
Dr. Dimitris, you want to add something while we are switching the screens?
Yeah, no, I think that this is sometimes important to know that if you try the facial vein and you can't because of the valves or difficulty, then another option is to try to go through the inferior petrosal sinus. Even though if you cannot see, you may be able to find your way there. So it's just a thought that it's sometimes it's there, but you may not be able to see it. You can actually create that channel to the inferior petrosal sinus and get access that way too, even if it doesn't show.
Okay. Can you see my screen now?
Yes, Sri, we can see your
visible
screen.
now.
Yeah, we can.
I'll just show you the angio we've done today. This is an external carotid injection on the right side, which shows an indirect fistula. And you can see through the intercavernous sinus, it's filling mostly on the left side. And we can see this angular vein coming down to the facial vein. And at the mid part of the face, it dissipates into two branches, and the lower portion is quite small. Okay, initially, I'll just show you the ICA runs as well. Yeah, this is ICA run again. Okay, here again, the lower portion of the facial vein is quite small.
No, but this, Sri, actually, it is not too small, seriously.
Yeah.
I would definitely have taken a catheter and try to hook at the mouth and take one of these micros. Duos like in a situation like this, I would use a two-tube duos from a headway duos and a synchro wire, and I'm reasonably certain we could have gone up without much of a problem. And only if that fails, I would try direct. I mean, this is our approach. You could have a different approach which works for you, but this is something we have standardized completely in our center.
Yeah, we have a venous access as well. We tried hooking up the smaller channel, but the channel going from the bigger vein into that smaller channel was not that easy. So we are now trying to get access to this angular vein. With the ultrasound, we are trying to get access to this angular vein. That's where we stand. If we can get there, and from there I can put a micro and get deep up there.
So which point are you trying to access? At where?
Can you just point it out, Sri?
Yeah, sure.
I mean, are you trying to get it at the orbit level, or
just proximal to this where the vein divides? At this point is where I'm trying.
I mean, we can't see that. Do you have a cursor on the machine? I mean, you could just try that and show it. Because to me, even at this point, there seems to be a lot of arborization.
So what we also do, Dr. Matthew, is like we take a DAC 3.8 for support, because sometimes
Always. See, the thing is, when you want to go transfemoral, you need a very, a good sheath like an Ansel sheath across the atrium, or it'll buckle there. And then through that, we use the diagnostic catheter with the right angle to sort of sit on the ostium, and then we work from that point.
Yeah. So are you pointing it out, Sri, where you plan to puncture?
I'm not able to point out on the screen.
Okay.
For some reason.
Your cursor is not there, okay.
Okay, it's all right. So
is there somebody who's got a marker pen, Sri? Can just mark it on the screen?
Yeah, we can do that.
Yeah, just take a pen and just put it. So I think unless it's a direct output from your screen, is the cameras focusing the screen, or is it on direct output?
It's a direct output.
I think it's a direct output.
Oh, it's a direct output. That's
okay, then you need a cursor to come,
I think we can go out and with the cursor we can show you.
Or you just tell us, I mean, anatomically, where is your plan to touch it?
Yeah, anatomically, where the angular vein starts, from there you see that vein dividing into the one that goes transverse, the one that goes down as a facial vein.
Yeah.
Just proximal to that is where we are planning.
So you're talking of doing it in the face itself?
Correct.
Not close to the orbit?
Correct.
Yeah.
Not into the orbit, but on the face, yes.
Okay.
That's what we're trying now. As you can see with the second screen, the needle is in. I mean, we are just trying to check and explore if we are there.
We can't see the needle in. Which screen are you talking about?
The second one.
On the second.
See what I'm seeing?
We hope you're seeing what you're seeing, but is that an injection? The last one, yeah, I can see it now. Yeah. That looks pretty high, much higher than the
Correct.
angular
Then
vein.
we have moved down. I'll just show you.
Gaurav, some time ago, micros wouldn't do this job. Today, the wires and the micros we have sort of go through all kind of bends. Even we are surprised at this behavior. Even for the matter, when I was using the Cerebrace, the long distal axis sheet, the sheet takes a full 360-degree curve. If you can, when you're pulling on the suction and you take it up, and you say, "Man, this is unthinkable. We couldn't think about that some time back." So devices have improved a lot.
Definitely. So, Sri, okay, you are.
Yeah, this is where we are planning. I mean, you can see the screen now.
Yeah, we can see the screen now. We can see.
Yeah, we can see that. Yeah.
That's a micro wire you are poking.
Yes, I mean, not the micro wire. It's the guide wire.
Okay.
Yeah, micro guide wire.
What is the wire you using?
The wire that comes with the micropuncture set.
Correct.
That's very stiff, Srini. That's really stiff. Yeah. It doesn't bend.
Maybe a Traxxas may just pass through.
Yeah, I totally agree with Gaurav. That wire is not meant for this anatomy at all. It's meant for something else. And I think I would also think a Traxxas.
We haven't put the sheath in, so we are just with the wire, with the function needle. So we are gaining access. Once we gain access, I think we will get back to you.
So, Sri, what we're gonna do while you are doing this access, we get your plan, and I think Dimitris has a talk. Maybe we can get his talk and then come back to you in 15 minutes. Is that okay with you?
Yes, it's okay.
All right, perfect. Dr. Dimitris, are you ready for your talk?
Yes, we can start.
So.
Yeah, I have the wire.
Okay.
But hardly in the
Yeah, and I think you can switch off your mic. You can get into the same problem I got into. It's safe for everyone.
That was not a problem. That was fun.
It was fun.
It was fun
for the others, not for me.
No, it was fun for everyone, sir.
Okay. By the way, that was one. What do you call as uncensored? See, one of the problems is when the mic is on, you may be slightly stressed. You may tell something that doesn't sound very polite.
It's better than having a wardrobe malfunction just to have a mic malfunction. Okay, over to you, Dr. Dimitris.
Whatever you do, don't go to the bathroom with the microphone.
Yeah. Not, Dimitris, it's the camera on. That's the worst bit. And
we had during the WNC, Rahul got a phone call and he had his mic on. So he's talking and I could hear the other talk. So we made a polling voting. Do you want to hear the meeting or Rahul? And then it was so much fun. And anyway, I will start then. This is a very interesting topic and dear to my heart. I really want to know your opinion on this. This is a little bit of a challenging concept, is the issue of, obviously, we're trying to optimize the artificial intelligence in our stroke care because there are many reasons for that. And today it's very standard to have large vessel occlusion detection. That's probably one of the things that a lot of us are having. Now, more recently, you have aneurysm detection, subdural hematoma, and intracranial hemorrhage volume detection. All these things are becoming part of our life and the screening of our CT scans and MRIs. Now, we have now installed in our system and as a research tool, Things, and this is basically a non-contrast CT detection of large vessel occlusion. And of course, the obvious interest here is that you can do the basic assessment of the stroke with the exam, and then you do the CT scan to rule out hemorrhage, and then you could do, instead of, at that point, you can actually call the team in if you think there is an LVO without contrast. So this can be a savings in some centers up to 60 minutes. We actually were very surprised, that if you look at this workflow here, either a mothership or in drip and ship type of situation, that this can be extremely helpful to have a detection, even in centers that don't have CT perfusion or CTA capability. You could start with the CAT scan. This is a work from the Barcelona team. Mark is there. He perhaps can comment on the success of this approach. The Methinks LVO Plus is when you have the detection added the algorithm to NIH stroke scale. It enhances, you can see here, depending on the very high sensitivities and specificity of detection of large vessel occlusion, no contrast when you have CT scan, Methinks, and NIH stroke scale. And this is also pretty good also by location. Obviously, posterior circulation and distal vessels is a little bit of a challenge, but this is constantly being improved, and I think is a huge step towards, we saw in our center at least a 30-minute in average improvement of time for decision if you were to decide on going to Angel Suite based on just a CAT scan without contrast, or deciding on transfer to the comprehensive stroke center. Another area that has been really exciting is the detection of aneurysm and potential aneurysm change over time. So this is a tool that I think is here to stay. I think a little bit more even how do you embrace if you have a case that you are considering to treat. Be very much, yesterday we talked a little bit with the Australia team of having, the basilar tip aneurysm. You do the aneurysm, you send the segmentation to your system for reconstruction, and after segmentation is done, you get, a tremendous analysis of the aneurysm center line and the planning for the procedure. So I think this as a destination for our the AI will hopefully be much more in the room with us, not only in our CT scanners. And I'll show you a little bit of a concept that I've been working on, which is, I'm gonna stop sharing here and go to my other presentation, because I think that this will help you to understand a little bit of where we're coming from with this. So this is now a concept that we're working with Mantis to have in the room the use of 3 modalities. So this is actually in the Angel Suite. You're able to have the ability to do your simulation with digital simulation. So you get the 3D model, or you get your DIACOM from the 3D spin, and then that file is sent at the same time for your haptic simulation, like we have a G7 simulator in the room. So this is the 3D acquisition. This is from the Iacono. So the Iacono has a relationship, Methinks, with Mantis and Siemens. And you can do the case planning. So you can use Ankitas. It's a different software that is device specific. And of course, do 3D printing and put your simulator to do, and this is the digital simulator. So you have 3 forms of utilizing the data set in your Angel Suite. So it's not like in some hidden basement for just training and simulation, but this is part of a real-time ability to get that information and upload to your system. I'll show you a little bit how this is done, just so you can understand. So this is basically getting now the data file into your G7, which is the haptic simulation, and you can stitch that to the vascular anatomy. I'll show you here. You see here, so you can see that that anatomy is already in place. So you just stitch the new anatomy into it, and when you do that, you now can actually use virtual catheters, different ones, to practice the deployment. This is in the Angel Suite. I'll show you how we have our setup here so you can see. I'm just going to move on here. This is the simulator now, And we have this monitor just behind our control room. You can see here, there. So this is me doing the angel suite. I will go back here. There. So this is in the back of my control room, basically. And you can actually do the case right there and then after uploading that from the angel suite. You can also, in the same monitor, use that for this type of simulation. So you have Cure, Ankiras is one that Mentis owns, and the one I showed earlier was Endovantage that is now owned by Rapid. And this one is very interesting because you can actually do overlapping flow diverters. You can do tandem and simulate most of the other systems. You can do only one flow diverter at a time. And so this is really interesting be able to do that, especially for reconstructions like this. And you can now decide where your devices are going to be, and you can see the reconstruction here like that. And then the third phase of this, so you have the digital simulation, you have the device-specific simulation, and now you go to the other part of this, which is basically the physical simulation. And in this case, this is a company that you may have heard from. It's called VastSim. You send the same data set, they'll do segmentation, 3D printing, and this is sent back to you. I'll connect and try to move fast through this. So this is the 3D printing, and now you see that the case arrives to our house. You get this little box with your 3D printed. Usually takes just like a few days in the United States to have this available to us, and then you can connect to your Angel Suite and have your actual real device deployment. So I will go back into my presentation. So why I showed you this, because I think it's the management of our information that is really crucial nowadays. So the integrated stroke network that we're working and designing, it means that it's how we manage imaging information and data in general. Today, we have a lot of problems. It's always silos. So if you take pictures in the operating room, or if you go into endoscopic data or MRI or CT scan, the patient information is all over the place, different types of PAC systems or databases, and is not many times connected to clinical information. So these layers of the imaging are usually separated in these 4 categories, and how the data is analyzed in the system. And I'm not going to stay too long on this, but just to show that radiology has their own, pathway, cardiology, women's health, everyone has their different silo. So it gets very confusing, especially now if you add the different types. We have dozens of artificial intelligence for different types, and each company is coming with multiple algorithms. So if you keep them all separated without standardization, it's going to be very difficult to actually get a final report. Today, if you have more than one LVO detection in your center, you have 3 or 4 different reports coming with the same patient for detection of LVO, for example. So there is now these solutions that are basically AI manager of AI. So it's basically the images are coming and they are all going, standardizing the images to the patient, so you're connecting to the patient, and then this AI will assign to the AIs that are needed to interpret the standardized image, and then send it back into for reports and connection to the electronic medical record. And this is the part that is essential, is how we manage the data and how we connect this information from the different AIs, different type of sources of images from the patient, into something that we have to have a way to, if you think about how you use that data, not only for clinical purposes, but also research, is a gateway towards anonymization of the data, and be able to then to send out even to third-party clouds for studies, and then back to your system and insert that with placing the name back into the patient. So these bridges, we have something called Laurel Bridge that is basically getting all the destinations that you want to send an image, get to destinations, that gets out into this system called Ambra, which allows us to basically anonymize and send to research if we need to, and then back to us. So these gates are very important to have in all your scanners in your system. So just give an example of, imagine that a patient has a lung cancer, and you want to see how many patients that have 50 years old, they have this type of nodule over time that receive a treatment. So you connect to your electronic medical records, so you get the data set, medical information that is specific to diabetes, 50-year-old nodule of 2 centimeters in this location. And so you have the image and the clinical information together. And then you can actually see how this patient that now have a follow-up received a certain treatment, how many other universities or hospital systems that have the same patient that receive other treatments can potentially then collaborate on getting information of what happens to a specific patient. And so I think that this is a very important part of what we do. Is going to be to ways to get our data more specific to the patient and to specific treatment that we did, and compare to other data sets that are similar to that. But for that to happen, we need to have a system that is standardizing our images so that all the images are going to the patient in the same language or format, and then the AIs that are needed are used accordingly. But at the same time, you have a connection with electronic medical record to be able then to have these data sets as pure as possible. And then we compare apples to apples when you compare to other patients. And this diagram is just showing like we are increasing now with, I showed the HF OCT, that's all going to AI for segmentation and analysis. You have the Angel data set, and then you have the ability to plan the procedures in the simulation that we talked about. And then potentially the output of that is for treatment, if in case of robotics or so forth. So we need to start thinking of how we're going to deal with the data, the amount of data that we're receiving. And I think AI of the AIs is going to be a very important step towards this. So my point here is mainly as we're getting inundated by a lot of different algorithms to analyze our data, take a pause and think about how you're going to do in your system to organize all these different types of AIs that are coming, and how you're going to be a player on the world of data, quality of data that we can generate on this. It will be a loss for us if we don't do this early on, because we'll get a little bit out of hand on this. Imagine also if we start getting a lot of pre-hospital data sets too, which is very much a reality now already. Videos that are being done of patients having strokes, and then compared to the rehab videos. And all that is incredible and extremely exciting, but at the same time, a little bit chaotic. And so I will stop here and answer any questions. Thank you.
Wonderful talk as usual.
Dr. Demetris, so do you foresee a future where you think, when I was using the Coryndius, I found it actually not intuitive at all. In the sense like there is a single track running over there. The kind of push-pull technique that we are so used to is I thought, quite challenging on the way the Coryndius has been created right now. Do you really think that this platform needs a kind of a relook in the way, especially the knobs have been created? I mean, I just felt that we are not used to a rotate function. We are so intuitively used to pull and push,
Yeah, no, I think so far, I think it's really the deployment more than anything else. So we actually did I know that Sam Zidat is there, and we did actually in our lab deployment of Galaxy, Contour, and some flow diverters. That function is really, I think, very precise to a point that I think I can see the potential on that. The other thing is, imagine if that the center line for distal vessel occlusion, for example, we can actually have the robot follow, and during WNC we show also magnetic navigation. So imagine that you have a combination of bringing the catheters in a safer way, keeping them in the pathway, because you can get the 3D information to the robot in a way that we have a hard time. We certainly have a learning curve that's going to be much longer than the robot has. You know, when the robot is fed with that information. I have mechanically, I agree, there are many issues with the current model, but I can see the potential that this will, if fed with the right maps, it will take to the destination the devices.
Yeah,
And I don't know
I
if you
totally get
remember
that. I still understand that we are very early, and even I was foreseeing the point that we actually mark the points, and Cornelius actually takes the device to the point. And like I said, I agree. We either now it's pretty good for coiling without a balloon assisting, but it's a standard thing where definitely it seems to have it right. But when we were showing the flow divert, I was thinking that the system is really not planned for pull-push movements as much as push straight, and a bit of tog on the wire. But definitely, I think we are in the right direction. Yeah.
I believe I am so excited. In 2001, I had a system called Telstar, which was a magnetic navigation that we couldn't get through the FDA. It turned out to be an EP machine for called Niobe. Siemens bought it, and but we did the first neuro trial on that, and this thing was such an interesting concept. But the problem is that many times we compromise the catheter or the wire because we change the physical property to make magnetic navigation. So then it becomes too stiff, or to this. So I think that is the compromise, is that how the robot, how the magnetic navigation, all these things will come without compromising so much we've gained in physical properties. Like today, this facial navigation, I think this facial vein possibly could be planned and simulated up front. We can do that case, and then up front if you can do or not, and so forth. The catheterization, I guess the point I'm trying to make is, let's bring simulation and this data that we have to the angel suite, not keep into a basement.
Yeah, I totally agree. Lab. Absolutely, yeah. And what I totally agree that fact that if you can simulate in the lab just before you walk in and do the case, I think you got a great picture. I don't know if you're aware of this, the work in progress that Siemens has been doing using VR and the 3D data that they come. Even that I found to be extremely good. It's like you can really see the object, touch it, feel it, and it's all virtual. It's really not there. Totally agree. Yeah.
So we will have to go to Hyderabad now. He's ready with the case.
Okay.
So
we move on to Chennai, Apollo?
No, we go to Hyderabad first. Chennai, we have to wait for simulation,
okay.
as Dimitris said.
Okay, we are with Apollo. Okay. We are with Hyderabad, right?
Yes.
So can you just tell us where you're right now? We think we got your things in position right now. Yeah. Would you like to update us from Hyderabad?
Audio? They can't hear
Some
us.
of the cath lab. Okay, they're better now. Yeah. We can see a eclipse out there. We can see the wire. We can see the second catheter.
So his plan is to reduce the flow using the balloon and use detachable tip to put onyx. Suresh, can you hear us, or somebody
yes,
from?
Sir, yes, sir. Yeah.
Okay. So which onyx you are planning to use?
Flow arrest that we are seeing here.
Yeah.
Some flow is still there.
Yeah, that's usually the case with such high flow. So are you planning to use onyx 18, 34? What's the plan?
34, sir.
34.
34.
Okay.
Yeah.
So that goes the answer. Onyx 34 there. So there was a question. And which catheter it is? Which detachable it is?
This is Sonic 1.5, the length is 35.
35. Okay.
Yeah.
What is the blood pressure? Have you brought it down?
Blood pressure currently is 85, 45, 48.
So
We asked
you got a
for
mean
around
of 60.
70 systole.
Can we see some runs after balloon inflation?
Yeah, the last run which he was running was after the inflation. That's why he's saying that it's still running off a little bit. It's not a complete seal.
Yeah, there is still filling of the fistula. Yeah.
So, so the inset is right in front of the screen. So maybe the cameraman can change the position of the inset. Like we can see you overlapping the screen, and it's no more a direct input from your screen.
Yes,
Maybe we can go to your direct input from the screen.
This is basically, yeah.
No, enlarge the direct input. Enlarge the direct input. Yeah, that's better. That's better.
Is it still?
Yeah, yeah.
I think it's
better.
slightly distorted. I don't know why. And also I'm not sure. Is there an image over
What is the BP, blood pressure?
Sorry, you're saying something, sir?
Blood pressure. It should be down.
So are you satisfied with the reduced flow, or you want to put coils as Dimitris was suggesting to reduce the flow further?
I'm like the coil staying is also a difficult thing at this much of flow. I prefer to go with liquid embolically.
Okay.
Yeah.
Anybody from the panel has a differing or a concurring view on the same? Stephen?
So we've been using adenosine in some cases to stop the heart for 20 seconds while doing
blood pressure.
Yeah, we saw that yesterday, the pacing. Yeah, that's another way.
Observe the salt function.
Dr. Matthew, what would have been your strategy here?
So, as he has mentioned, if he cannot reduce the flow, liquid embolic agent, probably I will try the same.
You will try to?
Liquid concentrated glue, and then try to occlude with the coils. At least then coils will be able to stay. So that we had 2 cases in that we did the same thing like.
So the plug with a coil and a glue.
Yeah, try to release some concentrated glue at a point, and then you will be able to stop the coils by flowing because there is a significant flow, coil will not stay.
But the glue will also just fly off.
So that's what I'm telling. It's a concentrated glue. It will stick.
I agree with him. One thing, I don't know how comfortable you are, but if we use 80% glue, I think with a very nice curve on the catheter, we have done it. Long back, we used to use only glue in very high flow fistulas. The problem is the younger generation they are not so used to glue, but it still works.
I don't know, you count me on which side, but
I have done glue in very high flow fistulas.
So we used to do and we still do vein of Galen high flow with glue, but I have always find it will a little bit will always fly off. Your techniques are good, you can curve it.
See, a little bit flying, nothing happens.
Yeah.
But I have noticed that it's so much about ensuring that the microcatheter is nicely touching the wall of the vessel. And if you have low pressure, you can actually build it up. So it may look scary, but honestly, if you're used to it, you can do it.
So what we could also do is inflate the balloon as he has done. And these are all double lumens. So you can also put coils after you have inflated the balloon. So that's what we would have done, inflate the balloon, put couple of coils, get a seal, and you have a distal microcatheter, which will then be okay.
Yeah, I think, Gaurav, the one suggestion is you have multiple arterial axes. You could have one catheter into the venous sac. If you don't want to deploy because of mass effect or something, you can actually keep the coil even without deployment, but just create a large mass of coil so that will slow down the flow.
You've got a good slow flow now. That's really slow.
Yeah.
on the micro. It can't get slower than that.
Guys, I can't see the image. I don't know if it's just me or is the audience able to see?
Yeah, we can see the live feed from his monitor now in two planes. He just made an injection through the micro, I think. And there
We
is
are just trying to adjust so that you can see it. Just let us know whenever you are seeing
I
it.
got it. I can see it now. Yes.
Okay,
Thank you.
perfect.
I think that's a very good
So Suresh, are we ready to inject now,
flow rate.
or you are still contemplating?
Like we are trying to decrease the beat further. It is around 79 42. 17.
But you've got a pretty good flow out there. I mean, don't think this flow is enough for you to start injecting?
That is okay, sir. It's more of a more optimal.
I mean, you don't have to make his brain ischemic, when you've got your target flow achieved already.
So, what blood pressure you are aiming for?
Around 70 systolic, mean around 50.
Okay, and where are we now? We can't see the screen, like we can't see the monitor.
What's the BP?
Demoting, somebody show the screen, this one. So there
No,
is
you
a
can just say,
hemodynamic
you can just
coming on the
say.
right side lower corner on the screen. Yeah.
Okay, so it's pretty much there now.
It's nearly there. I mean, I think exact 70 may be a challenge.
Okay, sir. Yeah.
So how old is
So
the patient, by the way?
direct
I'm
feed
sorry.
from the screen, please. Direct feed, not
What's
the
the
camera.
age of this patient?
Sorry, sir?
What's the age of your patient?
21, sir.
Suresh, can we have the live feed from the monitors? Live feed from the monitors.
Prepare here.
A few points on these two. I think it's very important for everyone. The choice of a balloon is definitely a great one when you can, because it can be temporary. One of the biggest concerns with any pressure cooker situation is the issue of if you have a coil or NVCA plus an approximal end, and your catheter, by not infusing properly, occludes with so the distal catheter gets blocked, and now you lose your access. So be very careful on the technique of how fast. Always remember, if you're gonna do onyx to infuse the BMSO, take your time to preserve your catheter and not time with onyx in place without having movement of the onyx, with the risk of losing that access, especially if your pressure cooker is being done with a permanent occlusion of the proximal vessel.
Yeah, that's a very valid point. Suresh, we cannot see the direct output from your monitors. Can we go to the direct output? We're just seeing the back of your head predominantly.
Okay, 2 minutes. Onyx 34 ready?
We ask the person there to switch to direct feed from the monitor. Yeah, now we can see it, yeah.
We get the onyx. 34. So now I'm going to inject the onyx. It is 34 concentration.
Okay, best of luck.
Yeah, thank you.
So there's a dead space, and these balloons have almost similar dead space as your So no, he's injecting through a detachable microcatheter. My apologies.
That's
Yeah,
right.
yeah,
Yes,
yeah, yeah.
and
My
I think
apologies.
that is really important too because the detachable microcatheters,
I think your glue is coming. Yeah.
uh, the the blank
Yeah.
roadmap, I guess, is important.
Yeah, it's
There you
flying
go.
off. The onyx is, yeah, okay, it's better
Yeah,
now.
yeah.
Yeah. I think that's doing a good job.
It may
Oh,
still
it's
fly
moving.
off.
Oh, it's moving. We could just hold it for a moment. Yeah. Yeah. I think it's sitting. It's okay now.
Another important aspect is how many
Oh,
speeders
it moved. It moved.
Yeah.
It fly
you
off.
may run through the onyx very quickly here, so you may need to have more than one spinner.
Yeah.
Next on study.
Yeah, you need it pretty fast so that it forms a nice. Yeah, it's holding well now.
But like you like to wait. I would have like just preferred to inject very rapidly here and let it reflux back onto my catheter.
Once you got the reflux, then you're safe.
Yeah,
The flow drops dramatically, but I think the flow rate is still faster than what we anticipated.
Yeah. The vessel is
So it
bigger.
is going into the pouch now. You can see that there is
Yeah. On the AP, we can see it hanging on the pouch. I think it's a good time to fill it up now, before it moves further. The flow would have reduced sufficiently to. Yeah. Yeah, we can stop, push, because it's not moving further, so it's good, it's safe.
I think we are in control now.
We just got to make the plug a little more robust. That's all. I think you should stop.
Again, started moving to pouch.
Yeah.
But remember, though, the onyx is not adhesive; it's only cohesive.
That's the difference between glue and onyx. It's still. So you gotta that went forward, and the screen went out at the same time.
Yeah, no, that is the issue of the adhesive.
That's a problem with onyx. That's why if you have some coils, this is less. But having said that, I still like glue. I have no problem, 75% or 80% glue. It doesn't happen with glue,
But I mean, definitely there are many ways to if you had a catheter through the MCA feeder into the aneurysm, potentially will
What happened to that?
They're rectifying.
Huh?
They're working on it. Just a minute.
Can we go to Apollo Chennai?
They're not ready yet. They're not ready yet.
That may not be ready also. That access point has already taken out.
So we are back. We are back. So it's flying off.
Flying off, I can see.
Yeah.
That is in the sac.
That's not so bad actually, because it will do what the coils would have done. It will slow down the outflow a little bit.
It's not a good idea.
It's not good, but it's not bad, super bad either. Like rather than flying off all the way into the veins, it's there in the pouch.
That's fine.
It's looking okay. That's a very important point that Dimitris has said. I hope you have figured what he said. The big difference between onyx and glue is onyx is not adhesive. It's like toothpaste that's there. And so you need a cast which is kind of oversized to fit like a cork inside a bottle. Otherwise, the flow will cause the onyx cast to migrate forward.
It's interesting to see this low.
So a very nice sign that his flow is stopped is seeing the cast inside the sac is not moving anymore. So that works like a speedometer on your car to tell that your flow has stopped. It's only pulsation that you see.
It looks quite romantic.
You have to be true neurointerventionist to say that.
So you can actually say, I wanted it there, so I know what I'm doing.
Now, the question is, we have other feeders, and the only control we have is the blood pressure, right? The one has a balloon, and the other one, the MCA, we don't have any protection. Is that correct?
No, by the way, Dimitris, how secure are you when you deflate the balloon with this whole cast? Will it move forward sometimes?
For sure, not yet. I think that is a little bit of the question of how long we want to keep the ischemia there. But I think that the answer for me, probably I'll allow the reflux on the detachment area of the...
Because I think there is still some flow going into the sac, because that whole cast is...
it's not going, okay.
It
so
is
we'll stop. I think we'll try to go on to a little bit inflate the balloon.
I think what he did, he withdrew the detachable tip catheter, and that also increased the flow back. Whatever the cast was around the catheter, we lost that cast also.
Yes. So now the flow is coming from the other vessels, right?
Yeah.
Is that what it is? Yeah.
Can take an angio just to see what's happening. Is it okay with you? Again, move. You're injecting?
Yeah, injecting.
Yeah.
Yeah, load, fast.
That is going the secondary branch. There were two branches from the ACA. I think it's going retrograde into the arterial, right?
Yes, sir.
Yeah. It's going to several branches now,
Yeah.
And that's one way to ensure that your onyx doesn't migrate.
So, how will we decide on the end point? We deflate the balloon, take a run.
I think I'll allow for some reflex.
Yes.
Then I'll be more sure.
One thing is the question of is it important to have neuromonitoring during cases like this or not? I think that I have found helpful sometimes when I'm pulling the catheters out to see change on SCCP and things like that, so it allows you to dictate how much traction you're going to have. But overall, I think that a lot of the guidance is, of course, through anatomy, so I think both workflows are fine, but the traction on big casts sometimes can actually cause issues, especially going PCA around the brainstem. It's a really
when would you like to stop? Because I think you seem to have achieved your target, right?
Yeah, we'll take an angel.
That's what I was wondering.
We'll wait for maybe a minute or so.
Yeah,
you can wait for it to kind of stabilize, but
you can increase the beat. I asked him to increase the beat to normal levels.
So you can wait for some
But
time.
you can inject to see if the other feeder is filling or not. While waiting. No.
We could do a DSA before you change the pressure, right? I mean, you could be sure about...
Around 70%. 70. So this from right side ICA I'm taking.
This is, though you're taking a feeder, it still fills, which is what Dr. Demetrius was saying.
Yeah. Yeah, the plan here for full occlusion of this, one consideration would be to do this way. You will have to fight now a little bit of reflux versus filling the venous sac, and the other option would be to place a catheter on the MCA and occlude that pedicle too, but I don't know how many more. In the beginning, we were counting AC and MCA, but it's a large aneurysm sac to fill with onyx completely. I don't know if that's the plan. That's why the coils I thought would be a good idea.
Yeah, I think this feeder we can check now once the balloon is taken down.
Yeah, you are deflated the balloon, right?
No, we are still.
No, yet to deflate, sir.
Balloon is still on.
How is you brought up your pressure? Your map is higher.
No, it is around map that increasing. It's around 70. Try to increase it more.
I admire you for taking this case up for a live telecast, because these are technically sometimes unpredictable, and I think good for you that you could demonstrate this unusual case this morning. So what's your plan after this? Would you like to stage the whole thing, or?
Actually, this therapeutic setting is like surgeon wanted to have a preoperative embolization kind of thing, or curative embolization. Both options he has given. If any remaining thing is there, he is happy to operate.
Yeah, but one sitting curative in this can be dangerous. There's so much of
flow is there.
Yeah, there will be a massive shift in the intracranial flow dynamics and can induce a bleed. Yeah, and I think operating at this stage also is extremely challenging. He opens up, every vein will be pulsating on its face. So
we try to reduce the flow and probably go for surgery at a later date.
Okay.
There's a plan.
Yeah, I think from the standpoint that you have taken a large feeder, but it is a relatively superficial lesion. In that sense, we could potentially go around and place clips on the arterial feeders and do that but you can do that endovascularly too. All depends. There is a cost to that too, right? The what you're doing, if you have to do it in another pedicle, it may be a little bit more. You need definitely more coils or liquid embolic and so forth. I'm not so sure that it's an issue or not.
Dimitris, now in this case, if you would subject him for a surgery, wouldn't the craniotomy be really large to go into each? Yeah. I know they do it. They clip all the feeders and then kind of take it in mass. But I was just looking at the spread of the disease. It looks like a huge craniotomy for the surgeon to isolate.
You have to have enough exposure to get to see everything. So that is a good size craniotomy. But I have to say, it's definitely something you can have control because of the location where it's located.
That I saw. It is just on the surface.
Yeah. So you see, balloon came down now, and looks like the cast is in position.
Yeah, it's not moved a bit. It's one advantage you got by going into the branches. They kind of stay like a, anchor, which is spread into the branches and stabilizes the cast a bit better.
Yes.
Are you planning something more this morning, or are you willing to stage it?
Okay. Sorry, sir, I didn't get you.
No, I'm asking, are you planning to stage it, or are you going to go ahead with another feeder this morning, or you want to call it a day?
I want to target the MC feeder, sir.
You want to target them.
Okay. So what we will do, Suresh, we will let you go and get the access on the other side, and we move on. So we will let Dr. Dimitris also go. He has been kind enough. It's late night at his place.
What time is it there today now?
It's almost 11, but we were together at 4 a.m.
Yes.
And my day never stopped. So I know you guys went to bed and back, but I've been in surgery all day.
You have been there whole morning.
Can I have a big applause for Dimitris?
Yeah,
like he has
thanks
been
so
there
much.
for 24 hours with us. Thanks a lot. Thank you so much. And what we're gonna do, we're gonna close this session, and
I think there is some question from the audience.
okay. So we close this session, and I think let me just also announce Dr. Matthew Charan is doing such a wide moderation, so you will continue as a moderator for the second session. And
I just want to say very, very impressive, and congratulations on everything. I think this is, I know how difficult it is to put a meeting like this, and it's been great to be part of it. And I definitely just have to congratulate you for the organization and to put all this together. Looking forward to join you guys next year. Okay.
Thank you. Thank you so much. Thanks a lot. So we close the session.
So I'm very impressed. Your intubation time 5:30 a.m. Patient on table 5:30 a.m.
Yeah. Okay. May I ask the panelist for a photograph, and then we invite the next panelist. I'm doing your job. Don't worry.
So if anybody has any questions on this last two cases that we saw, the one that we saw from Hyderabad, where they tried an access and like we were...
While we are having the photograph, can I invite the panelists for the next session? Dr. Anil Karapurkar, sir, please. Dr. Ashwini Chaudhary. Sir, are you here in the hall? Dr. Vivek Gupta and Dr. Vivek Singh.
Show the camera.
Come up here, sir.
I just want to say something about the previous case.
So you come up and say, sir. And while we are all just setting up, we will do the lucky draw now. Come. Sir, before you say that, you need to do a lucky draw, sir.
Lucky draw.
Kind attention to all our delegates here. We do have a surprise for all of you. As you all know, the people who arrived inside the hall area before 8:10 a.m. were the early birds, and we have collected their names, and they are entitled to, participate in the lucky draw contest and be the lucky winners of our 2 giveaway prizes. The second prize is an Amazon voucher, and let's see who the winner is going to be. So, chit has already been taken out, and sir, who it is?
It ends with Chaudhary, and so it's Ashwini Chaudhary's.
Ashwini Chaudhary, sir, is already here with us. Congratulations, sir, for winning the Amazon voucher. Now, we are going to announce the big mega winner, which is the first prize, which is an iPad, and let's see who the winner is going to be. So we are shuffling, and we are taking out a list now, and let's see who the winner is going to be.
Don't tell me it's Chaudhary again. But it's not Ashwini. It is Shubha Mitra.
Shubha Mitra Chaudhary. Not here. Lost. One chance came and went by. We are going to take another name out of the lot. Shuffle. And let's see who might be the lucky winner of our first prize here.
Alani Swami Prabhakaran. Is your
Dr. Prabhakaran, yes, he's right there and he wins an iPad. Congratulations. Can we have a humongous round of applause for our winner here today? Congratulations, sir. And we will be giving you your prizes at the evening, so you have to stick by till the end of the day. So do you all. So before moving ahead, we have our venerated moderators as well as
Yeah.
panelists here for our next session. I would request the moderator, sir, to please take the lead on and curate the second session of the day diligently. Thank you.
Dr. Matthew, you are the moderator for this session, and Chennai is live now. You can moderate from there, here, your choice. Sir, it's better if you can come here so I can coordinate with you. So
Yeah, hello. Hi, Saurav.
We're gonna like swap back and forth.
Oh, okay, fine. Oh, Sri, are you live now? Okay, I think.
Yeah, we've moved on. I mean, our intervention radiologist, Dr. Satish Ramurthy, tried the angular vein, but he felt the channels were too small and he was not able to place a sheet. And so we have moved on to cut down. We have just exposed the superior ophthalmic vein by cut down, and we are going to cannulate it. We'll just show you briefly the superior ophthalmic vein, okay, which is taken out with the loop, as you can see here. I don't know if you can see clearly with the camera. We have, yeah, and can I have the Doppler, please? Okay, Doppler on. So this is the intraoperative Doppler we use.
It's pretty okay with us. I mean, you have still not cannulated the vein. You have just exposed the vein, right?
Yeah, we have just exposed the vein. We just want to show you the vein exposure.
Can you just tell us where exactly is your cut down, at the level of the brow, or is it somewhere else?
It is just below the brow. It's an eyebrow incision, but just below the eyebrow. And we have first done a torsography, and then we have just exposed it just below the eyebrow.
Yeah, that's a classical site.
Yeah.
And you can see the vein, or you're just targeting the vein with your Doppler?
We have exposed the vein. We have exposed the vein with the vascular loop, and we have got the vein under control, and we are going to puncture it shortly.
Who's the other center this morning?
Yeah, you can see the. Can you hear the flow?
The other center this morning is Dr. Arulkar from Pune, and we will be swapping in between to that center too.
Okay, we will get back to you once we gain control of the axis. Thank you.
Okay, let's go down to Arulkar Center.
I'll just present the case for him, and then we go to Pune. So 58-year-old female with the history of recurrent episodes of giddiness, vomiting, gait ataxia, and the last episode was 2 weeks back. She is diabetic, hypertensive, and she has been on dual antiplatelets with best medical management, and despite that she is having recurrent episodes, so you know where we are going with it. So there is a tight stenosis in the left vertebral artery intracranially as it comes towards the basilar. And the right side is also showing some mild stenosis. So the plan is to stent this artery, and we go to Pune now to Dr. Alukar.
So for people who So Dr. Arulkar does a lot of work on intracranial ICAD, and he predominantly uses coronary stents. Good morning, Dr. Arulkar. Can you hear us?
Yeah, I can hear you. The volume is low. Can you hear me?
Yeah, we can hear you quite well. So would you like to tell us your plan before we go?
I think first my friend Pratik will present the case in detail, and also the DSA, he'll show the DSA pictures. Pratik?
Yeah, the case has been presented. Maybe you could just tell the plan before you,
so this is a 58-year-old lady, diabetic hypertensive, She has presented with multiple episodes of strokes and TIs in the vertebral basilar territory. 6 months back, she had a right occipital infarct. About a month back, she had a left occipital infarct, small infarcts on MRI. And even after that, instead of being a dual antiplatelet, she's had TIs twice in the last 1 month. The last episode was around 10 days back. TIs in the form of imbalance and slurring of speech. So she was on dual antiplatelets, clopidogrel and aspirin 150 till about 10 days back, and this was changed over to Brilinta 90 mg PD and ecosprin 75 GOD around a week back, 10 days back.
And how long do you continue Reliant and aspirin? Do you run it for a year, or you would like to stop it after a couple of months?
After the stenting, Brilinta and aspirin will be for a year, and ecosprin, only ecosprin after that. Okay. There will be a 1 year follow-up DSA, based on which we'll decide.
And what's the stent you plan to use this morning?
I plan to use a drug-eluting stent, and the hardware which I will use is 8 French short femoral sheath, a 6 French by 70 centimeter shuttle sheath, which I packed in the subclavian, and over a synchro wire, I will be delivering the stent.
So you are not taking a DAC or anything into the vertebral?
Cat 5, sorry, I forgot.
You got a Cat 5, yeah. I mean, that's a combination we used to. We would have the long sheath in the subclavian, the Cat 5 as distal as we can. And I think a coronary stent is a great choice in this location. So which are you using? Which coronary stent?
This is a stent called Cruise from SMT, made in India stent. It's a drug-eluting stent, sirolimus coated drug-eluting stent. So Pratik, will you show the DSA pictures, which we had done 10 days back?
We have the DSA images here with us. So where are you at this moment? Have you got your long sheath in or the DAC in? Or?
Yeah, I'll show what I've done till now.
Yeah.
It is nice to see that you're wearing the protective glasses also.
Yeah.
I think it is very important for us where we get long exposures to wear these protective glasses.
I've started wearing those regularly just a couple of weeks back when my ophthalmologist told me that radiation not only can affect the lenses but also the retina. So before that I used to wear it intermittently, but in the last few weeks I've been wearing it daily.
They're kind of
very good.
A little heavy on the nose, so can we see the case? I mean, the fluoro.
She has. There is a tight loop at the origin of the vertebral artery. So in such cases, usually I manage only with a 5 French envoy. But here I thought the artery is a bit thin and there is a tight loop at the origin and some mild stenosis also at the origin. So I thought envoy will not be a good option.
So this is an injection made. We can see your long sheath in the subclavian here.
Yeah, there is a 6 French by 70 centimeter shuttle sheath in the subclavian. Next one. So over a Phenom 27 and synchro wire, I have taken the Cat 5 as distally as possible.
And Cat 5 is an extremely trackable DAC. I mean, we find that it's extremely good. It goes as well as a microcatheter.
Right.
So here, if I may add, it is important to maintain that curvature soon after the origin.
Yes.
If we straighten that, the artery goes into spasm.
More than spasm, it arrests flow because of accordion.
Yeah. So it becomes, there is spasm actually.
But would you be too bothered about that at this moment, considering there's a pretty decent vertebral on the opposite side?
Yeah, there is some spasm, but I'm not worried because the other vertebral is fine.
Yeah, so I wouldn't be too bothered, but I would still use a Cat 5 because not here for the bend, but I would use it more for the support. Because the bend, I think, as soon as the catheter comes, it straightens out. But if the vertebral is not there on the opposite side, then of course it's a total different story and we really have to be careful. So it's a long lesion. What is the length of the stenosis, Dr. Avulkar?
Length is coming to around 28 millimeters.
20, okay. It looked a little longer than that.
Normal artery just beyond the vertebral junction.
So what is the length of the stent you plan to use? And here I can see the stent will go into the basilar itself because the stenosis is extending. So your stent is going to run from the basilar. So are you worried about caging the opposite side?
Contrast. So I'll just search for the right view for the wiring part. I think this is better than the previous one. Stop it. Back to.
So one important thing to understand is that you don't use coronary wires to cross these lesions because it won't take these loops. And it's ideal to use a wire either with a synchro or a Traxxas support. Some people do use the Asai also, but I'm sometimes not so comfortable with the Asai. So we also tend to use one of these combination. The challenge with the synchro is retention of shape, but in terms of toggability, there is no better wire than the synchro. I think it's torques the best. But in terms of shape retention, Traxxas retention is phenomenal. Yeah. Somebody asked, no, you don't use a drug-eluting balloon for angioplasty. You use a drug-eluting stent. And these are not peripheral balloons. You are going to be using coronary balloons, which don't come with drug-eluting. Asai loses its shape. Asai loses its shape, definitely not as much as the synchro, but the synchro select has improved a lot. But I think still there is a problem. Which drug eluting would you prefer ever? This I think is debatable. I mean, I think that it's just not the property of the drug, it's also how it's loaded onto the stent. Is it on a polymer? Is it bare? All of these matters. So I think the choice could be left to you and what you take. Any of them, to me, is pretty okay. Also, the stent morphologies. There are certain stents which are a lot more flexible and can take loops better. Here he's going to use a long stent, and that's why a DAC like a Cat5 placed across that loop will make a big difference. We can see something happening on the screen. So what is the balloon you plan to use for pre-dilatation this morning?
No, I do not plan any deep pre-dilatation.
You don't? Okay.
I do it only if the stent gets stuck somewhere.
Okay. So what is the diameter of the stent you're using? Is it 2.5 or 3?
2.25. Yeah. The artery just beyond the lesion is 2.2 and just proximal to the lesion is around 2.5.
So this is the synchro wire, isn't it, that you're taking across?
Yeah, this is a synchro wire.
So you can see that the wire moves very, very smoothly across. And there you are. So whenever you use a stenting, remember this one step. When you pull back the stent, the wire will suddenly move forward. So always keep looking at the tip when you pull back on the stent or balloon after the procedure is over. You can perforate if you're not careful about that. And the patients are on dual plate antiplatelets. Even a small perforation can be a disaster. So this invariably will happen when you pull back on the balloon after the procedure is over. And that is the time when you just relax and you think you've finished your job. Another step we always do is post-dilatation, the first angio is done with the balloon in the same position. In case there is a rupture, you can keep that balloon inflated and you may save the life of the patient. Small little tips, but it can help you, okay?
The wire seems to be in love with the icon, not going beyond the icon.
No, it will go. It is just, this maybe if you take your, what I would have, if I have a balloon, there's one advantage that you can generally take the balloon up a bit and it's sometimes stable. This is just flipping. Yeah, it's gone. Oh, no.
Yeah, I'll comment later on the balloon part.
Yes, come down there.
So sometimes I just use it to stabilize the wire a bit, that's all.
The challenge here is always we want the wire to go as a loop.
Yeah, so that's a problem. When you want it to go into the ICA, it will never go. Otherwise, it will keep going there all the time,
Yeah, so we want the wire to go in as a loop, but if you give a tight shape to the wire, it will not cross the lesion.
Yeah, it will not cross the lesion. But you have crossed the ICA, no?
I cross the ICA.
You have come right to the post PCA now. Great. I mean,
I'm in the left PCA.
yeah. I mean, you have got in a great position already.
Yeah. So
that should be enough. Yeah.
We'll take a run because the anatomy will surely have changed.
So that's a very important step that Dr. Arulkar is saying. Your anatomy has changed. Don't go on the roadmap. Make sure you understand the proximal and the distal portion. So your stent is going to cage the opposite vertebral, isn't it?
Yeah. My God.
What happened? No, did you want to do pre-plasty? It depends. I don't. Dr. Arulkar says he wouldn't. I may have done it because sometimes you go in and the stent doesn't move freely. Especially in a drug-eluting stent, you sometimes wonder whether it's peeling the drug off, but it's a choice, depends on the operator. I know it looks like everybody is voting, there's only one vote. See, the thing is, somebody asks coronary versus neurostent. The problem with the neurostents, they're not drug-eluting. So I agree that if there is a way that you can put a coronary stent, the advantage is the patency is going to be much, much better than with the available. So Credo would be the neurostent that you use. And Credo's, it's not a drug-eluting stent. It's a laser-cut nitinol cylinder. Again, like I said, we are not arguing which is the ideal stent. But in this place, even I would have put a coronary stent, which is drug-eluting. So which is better? And now you see, it is not like which is better, which is possible. I still believe that coronary stents in a location which possible is a good choice, but sometimes they don't track, especially in a very tight siphon in the cavernous segment, and then you will have to use a Credo, which will take that bend because if the micro goes, it will go. So that's the other question.
This used to be the case when we did not have very good access products.
Yeah, true.
Last few years, I've hardly had a case where the stent has failed to reach even in the active circulation, even with the tight siphon.
Dr. Arulkar has never used neurostent. So that's one extreme of the spectrum, and we use both.
I've never had the need to use a neurostent, fortunately.
And he's got very good results and a very, very good number. So his experience is good in this area. So like I said, but if you're a beginner, a neurostent is much, much easier, without any doubt. On the cavernous segment, on the vertebrobasilar, coronaries also are very easy to take. So you could choose. But remember, a drug-eluting stent has an advantage. Then sometimes if the perforators are coming across the segment, we tend to underdilate and put appropriate size stent. That's again something that I do, which with Arulkar doesn't, because he has been having very good results. So I'm worried when there is a perforator across an M1 stenosis, and then we would also be careful. You can see the Cat5. Can you see the way it moves? It takes that loop effortlessly. It's not even, looking like it's got an effort out there, That's your stent across, right? I mean...
No, stent is not yet across. There's few millimeters left. I'm being very gentle.
No, not across. I mean, it's beyond the Cat5. I can see that, right? Yeah. So the Cat5 is kicking back because of the resistance offered by the pusher.
The problem here is the length of the stent.
Yeah. That's why I said you need a DAC, because you got a long stent. If it was a short 15 mm stent, you'd have easily gone across. What's the length of your stent here?
Here I'll have to go by the roadmap for the positioning, because
nothing will flow.
There will be no contrast across the stent.
This, of course, if you're a catheter on the opposite side, would have helped you, because that would have shown you the basilar. But you need your positioning well, yeah.
Right. I think you're okay.
I think it's good to take an injection anywhere, Arulkar, because you never know. You may get a trickle going across, you know.
Yeah, not a bad idea. I'll take an injection.
It's his experience that makes him decide whether or not to predilate, but predilatation also makes the stent going up a little easier. And also sometimes you'll see some flow by the side. So here we don't have.
Yeah, so I have to go by the previous roadmap. As for the previous roadmap, I have entered the basilar.
Would you like?
I'll still take the stent a couple of millimeters.
Will you push? Do you want to push it at least 2 or 3 millimeters or more into it, or you're happy with this position?
No, I'm pushing a couple of millimeters inside.
Yeah.
Because
that way we are sure that we are. So the orbital margin can be used. That's gone. That's more than enough. Yeah. Yeah.
Just take a run again to see the.
So it's purely his experience. He was quite sure he could do it without a predilatation. But I agree with many of y'all that you would still like to predilate. So remember, you go very gentle, very slow, because unlike coronary vessels, the collagen matrix in the neurovessels are much smaller.
We'll start inflating. The inflation has to be very
slow. Remember that it's very gradual, very slow. Take your time and then deflate. Keep the balloon in. Take the shot, and then when you're very sure everything is off, only then you pull out the balloon. Also notice when the balloon is pulled out, how the wire will keep tracking forward, and you have to keep an eye on that, or it can suddenly perforate. Yes, always long stents are more difficult to track. Predilatation helps, but more than anything, you need a good support system. So make sure you have a DAC. You could use a 5 Sophia or a 5 Cat5. Both are very good catheters for that support. And that should be inside a nice long sheath. And like he used a 70 centimeter Cook Ansel sheath, that would be a good choice because it ensures that it doesn't fall out. You need that support system, you know. So in the vertebral, it is a long sheath in the subclavian artery, the DAC or the Cat5 in the vertebral artery, and then you do the procedure. Rukar, what's happening?
So I'm inflating the stent very gradually.
Yeah, we can't see the screen. Can we see the screen as we inflate?
Can you see it now?
No, we are only seeing you.
Yeah, can you show the screen, please? 2.5. Can you see the screen now? Yeah, you can see the screen.
We can see the screen, but we don't see the inflation. It's like a still image that we see.
It is still not inflated. I'm going very slow.
Okay.
3. It's still at 3 atmospheres, long way from any inflation.
Yeah. See, it's a very important step. Somehow we notice that slow inflation rarely produces a rupture, but something that is really fast boom can have problems. So it's good to go slow.
3.5.
Is your nominal 12 on this?
Nominal is 8.
8.
Okay. 4.5. The proximal part has started opening up slightly, if you can appreciate.
Yeah, I mean, I think both sides,
Yeah.
both ends open together, and then finally the stent. The roadmap is not so clear, but I think that.
Yeah, I think the image quality what you see there is a bit lower than what I'm seeing here. There was some issue with the setup last night.
Yeah, but we could see it very well on the live fluoro, you know.
What is the length of the stent you said?
Pardon?
What is the length of the stent?
28 minutes.
28.
Can I? 5. On the.
Can we see the live fluoro rather than the roadmap? Because the roadmap is really not showing anything. Yeah, that's better. So you can see the stent slowly opening up here.
5.5.
In the meantime, at Apollo Chennai, they have they have actually cannulated the vein. And the great advantage of the ophthalmic axis is, after that, it's a super fast procedure there. You know, because it's an absolutely straight highway into the sac, and this is a kind of smallish sac. So we'll just see that as soon as Dr. Arulkar finishes this case.
Single shot number. DSA. 6 here. Wait.
Technically, by SICK, you would see the stent open. It is just the lateral pressure on the wall is not optimal to ensure that we have a good opposition, but you can actually see it, that a stent is open along its length. A little bit on the center, you see it needs a little bit. And you understand in the intracranial circulation, you never look for perfect angiography results. That it can be a disaster. A little suboptimal is perfectly acceptable. Vessels rupture very, very easily. The elastic lamina is very poorly developed. And so we are always careful. And it's a sizing which is about 25% less than the target size of the vessels.
So there is still some waste left in the proximal part. The rest of the stent is open.
Yeah, but we can.
Yes, usually I stop inflating when I no longer see a waste. Even if it is subminimal, the pressure is subnominal. Sorry.
I think we can stop when we reach appropriate pressure. No time to really.
Yeah.
Push. And I have seen patients 10 years, though there's a residual stenosis of 30%, doing perfectly well.
I think we are done. I no longer see any waste.
Yeah, it's looking good.
Yeah. So the answer, view. Yeah. I think there is no waste even distally as well as proximally. Right? Okay. Deflate. आराम से पुल मत करो. Roadmap off.
Just one second.
So take a run with the balloon still inside.
We just take the angio. We'll look at angio and quickly go to this thing. Go to Chennai because they are ready and waiting. Okay. You know, that's.
I'll just take a run with the balloon
perfect.
outside.
Yeah. So you see that the first run is always to the balloon inside. And Arulkar, are you pulling the balloon out now? I just wanted to show them how the wire starts going forward as you pull the balloon, and if you're not careful.
Yeah, I am removing both together. Actually.
Yeah, okay. Have a look here.
The Cat 5 because even the Cat 5 will go and hit the stent.
Yeah. So 3 things will happen. Your Cat 5 starts going up, your balloon's wire starts going forward, and as you pull down. So one thing is pull the balloon and the wire together, and the Cat 5 together. So in that case, you can actually. So there is a kind of stretch that takes place always.
Withdrawal has to be very gentle, slow, because invariably with our stent system and wire, there is a change in anatomy. So in perforated rich areas, if we do it very fast, there is displacement of the artery and there can be evolution of perforators.
Now it comes back.
So right now I'm not happy with it.
So you get it. The technique is holding all 3 together, so nothing moves. and then you do it. Okay, one last injection. I think we have seen a beautiful demonstration of an intracranial stenting, very nicely executed. And of course, like I said, he didn't pre-dilate with his experience. Other than that, I think all of us agree that we'd have done it exactly the same. Yeah.
Yeah. So I think there is about the pre-dilatation. I'll just take 5 seconds of yours. I
by
don't
the way,
like
Dr.
it
Arulkar,
because
there is a pinching on the opposite side. You can see
there
that,
is some
but it's
damage to the intima with pre-dilatation, and it adds to the risk of thrombogenicity.
well,
There is some waste in the mid distal 1/3. I'll just take a few other views. If necessary, I'll have to go in and do a plasty with a short balloon.
no, but it looks good to actually. Seriously, there is a bit of a pinching off of the opposite vertebral, but that is expected to happen because the disease extended all the way into the ostium. So, Dr. Arulkar, we are just moving out to the other side because Srini is getting worked up.
No problem.
So, shall we give him a big hand? That's a beautiful demonstration. Thank you so much.
Thank you very much.
Let's move on to Chennai, Apollo. Pardon?
Before we move on to Chennai, there is a flash workshop in Penumbra booth on aspiration. So those of you who wants to join there, Dr. Mukesh Sharma and Dr. Khairul Azmi is going to be the faculty for that. We can go to Chennai now.
Hello, sir. Can you hear me?
Yeah, we can hear you.
Hello, sir. So we have done the cut down of the superior ophthalmic vein, and I've got the sheath in. I'll just show you the plain fluoro. You will get a fair idea of where my sheath is. Can you see this little curve? I think you're getting.
No, we can't see. I mean,
1 minute.
Make that a single screen, then we'll see it.
Yeah, single screen protocol.
We can see a kind of dot in the angle of the orbit on the right side. Maybe that's what. Okay, I guess we can see it. We can see a little dot. We don't have a laser pointer here to show it to the others, but we can see that. So what do you have over there? What is the sheet you have there?
Do you see something there now?
We can see that. We can see that, yeah.
Yeah, we have this 4 French dilator sheet.
Okay.
The micropuncture sheet, we have just placed it and we have secured it. Through which we have put the microcatheter, we have put an echelon 10.
We can't see the microcatheter. Maybe on the lateral plane we can see it, I'm not sure.
We can see the tip there on the right side. It's gone across the interconnectors.
We can see one on the lateral margin of the orbit. I'm wondering if that's what you're showing. I'm not sure. It's okay. Can you give us?
I need to see what you're seeing, because here what I see in the screen is different.
There is
from
one
what,
dot
you're
on
seeing.
the orbit on the left side. Is that what you're showing us? I think that's the one you're showing.
No, it's on the right side. The dot is on the right orbit.
One
medial wall
dot
on the right
on
orbit.
the right side, medial wall. One dot on the lateral border, right side, and another dot. Yeah, we can see it now.
Yeah,
in
you
the
can see it
sinus.
now, right?
Yes,
Yeah, you can see the sheath like hooking up into the superior ophthalmic. If you see in the lateral, I'll just try to move it a little bit.
No, we can see it. It's fine.
Yeah, the sheath is all the way up. I can just
at the cellar we can see
better.
that.
And I have the echelon all the way up. I will do a microcatheter injection just to show where we are.
Yeah, he's across that.
The fistula was on the right, as you may remember.
Yeah.
And it was
filling the left.
Yeah.
Yeah. That
my
looks
microcatheter
perfect.
is right up there. Yeah. So we're going to start coiling from there, and my plan is to pack the intercavernous sinus quite strong. As I coiled initially, there is no big pouch on the right side. There's all little dural channels, but it reconstitutes where the intercavernous sinus is arising. So I'm going to go with the 3x8 coil, Orbit Galaxy, Optima coil, sorry.
3x8.
Yep. I just measured the intercavernous sinus is measuring about 2 to 2.25. So I want to just oversize it a bit.
We can oversize it quite significantly actually, because they elongate kind of a, it's not like an aneurysmal sac, so.
Absolutely, sir. I do agree with that. But the initial coil, I want to stabilize right there. And then as I move along, I will oversize it quite a bit.
You don't have a biplane there, isn't it? You can't.
We do.
Is it possible to see plane A and B together? Yeah, okay. Yeah, now it's much better, right.
Yeah, I've just done an oblique on the lateral because both the cavernous sinus were overlapping. I can oblique it even better.
No, this is enough, it's fine. As you put the first coil, we'll see that more movement. Yeah. So technically, this is the main the most difficult component of a indirect CCF. The rest is easy. There is no rupture. There is no technique involved. You can give it to your first year resident to push the coils. It's pretty okay. It is. This is the only challenge, and then you may access it by drilling. You may access it by the facial vein. If nothing works, you can access it by percute cut down.
My previous experience, I've been like drilling quite a bit, but about 8 out of 10 cases, we were successful with the drilling. And the superior ophthalmic vein access, we've done only a few times. And this for demo, I thought it'd be better. So
the reason did you try the IPS at all? I mean, that's a question somebody has asked. Or did
I've not tried in this case because IPS drilling takes about 2 hours practically to get down up there. So I thought since being a live case, it'd be too boring for the audience. Here we are coming up with the coil.
But anyway, worldwide, the most standard approach is IPS drilling, and these are the alternatives when it doesn't work. Have you got your coil inside? We see some radio opacity. Yeah. We can see the coil going. Don't see the exiting, but I can see the coil.
Ceramic.
On the right side. Oil tends to come back, so I'm trying to pack it.
The coil is soft, it's sort of.
I think for the juniors, it is very important to see the site of the fistula. So in fact, I spend a lot of time moving the angiogram back and forth to see the site of the fistula. If you don't get the correct site of the fistula, it is virtually impossible to treat. And I've seen many people trying and finding it, doing something, but not getting the fistula. So we have to get the vein. The most important is we have to get the vein in any fistula, whether it's a duro-levi fistula, whether it's a spinal fistula, or whether it's a complex duro-levi fistula. Sometimes it's a single feeder, sometimes there are multiple feeders. So there may be multiple fistulae also in the same area. So what is important is to make sure that we have identified the exact site of the fistula. So here we can see the draining vein is mostly on the left side, but the fistula is on the right side. So if you try and just tackle the left side, the actual fistula will be left behind, which will still need to be treated.
Absolutely, sir. I do agree. And we'll just do a run. We have just placed the first coil. I try to pack as much as possible in that angle. Yep. We'll continue to pack it.
Yeah, you still haven't got all of it.
So the target is always that one point where all the arterial feeders kind of, it is like a receptor, and the receptor has to go. The rest is just the draining vein. And what Dr. Karapurkar is trying to highlight, look at the angio, find the receptor. If you find that receptor, that sac into which everything drains, that is the point of disease. And if you miss that, you will get into a bigger mess. So what Srini is doing is perfectly the right thing. He's gonna cross the other side, come exactly into the point where the sac meets, and he's packing it up with coils, and then he'll slowly come backwards with that.
So the first coil I've detached. I'm just trying to pack it as much as possible here because I feel packing here is more important than filling the whole sac.
You can also inject a little onyx or glue.
2 by 8.
Yeah.
Yes, sir. I have the backup plan. That's why I've got
Because this is very
Epsilon
safe.
10.
Yeah, and this is very safe.
So, Srini, we will leave you some time till you pack up and you tell us when it's over. We have Professor Yong who will be giving us a short lecture on the durability of the web. Let's just listen to him and come back. See, technically, after this, it's nothing. It's just putting coils and not ensuring that you pack them well. Don't let the catheter kick back before you got a good pack. And that's all. It's the access, like I said, is the most challenging. And you saw Srini, so a beautiful demonstration. If one fails, you got a second backup in mind, and one of them will work if you got the right team around with you. Who did the cut down this morning? Was it done by you or was by somebody else?
Yeah, I did the cut down because
great.
being a surgeon, it helps a lot. I
Yeah.
had the vascular surgeon by my side just in case.
Yeah, because not many neurosurgeons actually do cut down for ophthalmic veins. It's often a vascular surgeon who comes and helps us out. So as long as you have somebody on the team who knows this can happen, you will never back out of a case. Thanks, Srini, so much. We'll come back to you when you're done. In the meantime, we'll just finish this lecture.
Sure, sir.
Thank you so much.
Thank you very much. I'm back again. Yesterday I covered a very heavy subject like how to treat a posterior circular giant angiogram. Now I'm a little bit soft the project, like how to improve the durability of the web for the angiogram. My lecture is going to be a little bit subjective, so you may have a lot of questions. So whether you like or not, worldwide trend is, we do use stent a lot, like just for regular MCA aneurysm, they do use stent and coiling, and we have to use antiplatelet agents. So I would say there is beauty of surgery. So I did 6,000 annual cases by myself. Still, I'm doing the surgery, and around among the 6,000, I did like a 2,000 by surgery. But I'm still love the surgery for the MCA aneurysm. So I'm still thinking, there are a lot of renowned neurointervention in outside the country. They love to put the flow diverter for the MCA. But I'm still very reluctant to treating with MCA with flow diversion. But I'm okay. So there's some the annual which is not very suitable for the surgery, especially ACOM, in high ACOM. Yeah, the patient end up with a lot of olfactory nerve dysfunction. So at that case, I don't mind put the flow diversion. But especially MCA, I don't see any advantage of the stented coiling or the flow diverter, especially flow diverter. Then the surgery, I can provide like the direct surgery for 2 hours. So whenever I have assistants from neurosurgeries, they are neurosurgery resident. So I do ask, okay, this is your brain. What do you want to do? Okay, initially they want to do interventional way, but after get some surgical experience, okay, so they don't mind to get a surgery. But the problem is I met Dr. Alex Prensa, who is my teacher. So we had dinner at the it's Valdizen meeting this year. But he told me, Dr. Shin, do you still crack the skull? And yeah, I do. But still, I'm thinking the surgery provide a better result. But to defeat the surgery, when it comes to treat the wide neck aneurysm, we need some novel approach. So I think the web is one of them. And also, you have a contour here. Then we enjoyed the lecture from Osama yesterday. He provided with some seal. Then I think you can avoid using the antiplatelets. So I think it's kind of a novel way. Initially, several years ago, the one person from microintervention asked me, is it a good idea to acquire the web device to microintervention? So I said, okay, no, it is not a good idea. I don't see any advantage of web to treat the MCA aneurysm. So I believe there have been many materials came to the market and fade away due to its efficacy and safety issues. So I thought the web was one of them. So actually, I don't have that much experience with web like you. So among all my cases, I have done like 40 web cases so far because this is 1 or 2 years. So I'm first a web and user and proctor in Korea. And I've done 40 cases, but I did proctor for 30 cases, and proctor in Japan, I did 15 cases to 7 Japanese physicians as well. And so far, 2 years, so web in Korea, we have done 300 cases. So we do have a Korean registry. So we collected all data, not missing anyone. So until last month, we have done like 300 cases. So I think I'm able to present at the end of my presentation as well. You know that there's a safety in outcome and durability. So we need to get the 2 rabbits, like safety and durability. So before I came to here, I thought, the India has the very beginning of using the web, but I enjoyed a lot of Relive cases, but they are much better than me, and they do have some experience. So I just want to skip this video clip. So I always spend a lot of time to the sizing, and after sizing, before the procedure, I spend a lot of time, and then web preparation, but I just want to skip all the cases. So I want to also skip these procedures, but you can get a lot of good experience. So I just want to skip all the cases. Okay, this is my first case. This is going to be a more subjective presentation. So this is my first case proctored by the doctor from United States. This is an ideal first case. Bachelor top, this is the first case in Korea as well. And it was done. Actually, procedure itself was uneventful. And I think, we can get a pretty much good result. So this is a 1 month follow-up MRA, looks okay, but when you see the 1 year follow-up, you can see significant web compaction in the basilar top. And this is a 1 year follow-up. So actually, I didn't treat this patient because anyway, there is some web compaction. However, there's no contrast filling to the dome. So this is a 2 year follow-up. So I would say it's a relatively stable. So I didn't treat this patient. So this is this means a lot because size selection is very important. So if you got some inadequate word position, the web device may collapse under pressure, like when you see the left picture, and this is my case on the right side. But if you got some good word position, the web device resists compression. It is going to be stable and durability. But I think we can get a lot of web compaction. So did I do something wrong? No, I should have used the one size big. I think then we can change the story. This is another case. The ACAM annuum is relatively high, the ACAM. So I put the web. Initial result was excellent. I thought I got some very nice lateral compression. This is a very important part. But this is 3 months follow-up, was good. But this is 1 year follow-up. You can see significant compaction. So when you see the 3D, so there is some web compaction, and the recess, there is some contrast filling. So when you compare with the initial one, so you can see just 1 year, you can see very significant web compaction. Even though I thought at that time, I got some very good lateral compression. Still, there is a web compaction. And this is 62-year-old female. Actually, the procedure is uneventful. And this is 1 year follow-up. So you can see there is some compaction as well. And there's some filling of the central recess. So this is the follow-up angiogram. You can see there is some contrast filling in the recess. And also, compared to previous one, you can see about 30% web compaction as well. So did I do anything wrong? Something wrong? No, I didn't do anything wrong because that's the nature of the web. So when I proctor to juniors, because when I do proctor, they don't have that much experience. But the problem is, it's the safety issue is the most important part. So normally, I don't push very hard to get a little bit much more lateral compaction or oversizing. But once I have some experience, I was asked to myself how to improve the durability of the web for the aneurysm. So this is actually, this is a kind of an ideal web position, but it is not easy to get this ideal position because when you see three-dimensional anatomy, a lot of web end up with some dog ear on the just one or two branches. Sometimes if you end up with some oversizing, and you can end up with some compromising one or two branches like this. So how do we prevent this kind of phenomenon? And actually, this kind of the result are bound to fail because if you follow this patient, a lot of patients coming with compaction. If you got some dog ear, so to prevent dog ear, so you can use the balloon or you can use the stent as well. So this is the web stenting. The sizing is very important, so you have to spend a lot of time to get the sizing. So compared to I don't have any experience of contour, but web sizing is very important, but contour looks like very generous about the sizing. So I don't have any position to talk about contour. So sizing is very important. This is another example, the MCA. So once I got some follow-up data, I decide to change my strategy. So this is the MCA aneurysm. So procedure was eventful, but you see, even though I did try my best, but there is some compromise to upper branch and lower branch. Initially, I changed my direct device one size down, but I decided to put the stent using the upper branch. So I put the stent on upper branch. Still, this is a final result. Still, looks like the inferior branch, there's some compromise. So I decided not to treat because anyway, I want to give the patient antiplatelets. But this is a 6 months follow-up data. So very surprisingly, so I can get the very nice results with the upper branch and the low branch as well. Because initially there was a 30% compromise, but 6 months follow-up, I can get a very nice remodeling like this. I was very happy, so I think this is a good strategy, even though end up with using the stent. Sometimes, we can get a very nice durability. So is it good strategy, oversizing web, expecting web compaction? No, it's not easy to say so. So this is a better top aneurysm. And initially, we did observe this patient, but for 10 years of follow-up, the size is getting bigger. And I did put the web. But as you see here, both PC were compromised, but very luckily, this patient has a good collateral from both PCOM. So actually, I decided not to treat. So I didn't put the stent, I didn't put the balloon, just this is 1 year follow-up because I thought there were like 80% compromise of the PCA, but this is 1 year follow-up. So I can get the very nice remodeling and get a very nice PCA. I don't think we can get the same result, but this case representing a lot. So without oversizing, no, I don't think I can get the very good durability like this. So this is representing a lot. This is just initially I thought about 80% compromise, but 1 year follow-up, I can get a very nice remodeling. So this is my series. Exacting all the proctor, this is all done by myself last year. This 33 cases, and actually the result was excellent. So about the safety issue, actually I haven't experienced any problem. I have 2 minor symptom problems, but no, I haven't experienced any serious complications. But according to result, so maybe you think it's good result or bad result, but we can get a pretty good one, and 78%, still around the 20%. So I thought the result was very disappointing like this. But once I get some oversizing technique, recently I got some follow-up data, and then I can get a better, way better the result after doing the web. So this is, I had just 2 very minor complications. This is a complication 1. This is actually the second case in Korea. Initially, I can get a very nice result, but after discharge, because at that time, the patient got some just aspirin only, and 5 days after discharge, and the patient came to the ER with a very minor weakness, and the symptom has been improved just with the dual medications, and follow-up angio shows complete occlusion after 5 days. This is another case. It's also a very beautiful case. But after stop the aspirin for, I keep the aspirin just 30 days. But after 20 days after stop the aspirin, the patient came to very small multiple embolic infarction. But this is angio shows good result. But I decided to put some more the aspirin. So after see this a little bit small infarction, I decided to, okay, even though whether I compromise the parent heart or not, I try to keep the dural antiplatelet about a month and the aspirin about 3 months. However, it depends on the result. This is a corneal web registry for just 1 year. So actually, I'm the first proctor and organizing all the registry. So for 1 year, we did treat 172, but until last year, we did treat 300 cases, all Korean. We didn't miss any cases in Korea, so maybe I'm able to present all the cases. So among them, this is a result. They're including rupture, 8 rupture cases as well. And this is the web device change in 26 instances. And this is a pre-medication. And this is the microcatheters. And we didn't use the stented coiling at 10 cases, microcatheter protection 7, balloon as 2. And there were very, actually, I would say the procedure event was very minor. And most of the cases was okay, but we had 2 rupture case. One patient was okay, but one patient died. So this is, we have a very minor cerebral infarction as well. And actually you see here, the follow image, we can get 85% of the WSA and B, and result was not that bad. The summary, I think, is a webbable, we can apply for some selective bifurcation aneurysm, and antiplatelet medication is very important as well. And there's very acceptable safety issue. But we also provide a favorable follow-up data. But from my experience, the follow-up data was a little bit disappointing. That's why I changed my strategy. But whether you like or not, I think there are a lot of what they came to the market fade away. But I think I love to use the web because this is my kind of last case. This is a relatively big aneurysm, but I was able to put the web in less than 10 minutes. So I think still web is not the material fade away from the market. So this is summary. I had 2 minor complications without any permanent neurologic deficits, but durability is not superior to any competitive materials. So initially, I did fit the aneurysm site to the aneurysm. Still, when I the proctor, I think the safety is the most important, but I don't want to have them oversizing when they do have that much cases. But recently, I do oversizing, but after oversizing, follow-up angiogram shows better radiologic outcomes. So that's it. So I think, as I mentioned yesterday, I do host my international conference BNS like this in every year in Busan, which is a very oceanfront city in Korea. So you are more than welcome to come to Korea and Busan. I'm working at Seoul, but I'm born and raised Busan. And I'm pleased to announce, I also hosting to 2026 WFITN in Busan as well. So you are more than welcome. Thank you very much.
Thank you. Thank you, Dr. Yang. Just one question. So you routinely use antiplatelets before and after?
Yes.
Yeah.
Because sometimes we can change our strategy. So always I just put the antiplatelet before the procedure, like 7 days before procedure. And after procedure, dual antiplatelet for 1 month. And aspirin 3 months until I have a proven evidence. So actually, one of my case, actually the patient present with a little minor thromboembolic, infarction. However, angiogram shows great. So actually, I don't like the proximal marker as well. So anyway, I think still I believe it's safe to using the antiplatelet for a while. So I keep 3 months.
Even in a ruptured aneurysm?
No, rupture, I don't have one, but in Korea, we have we have treated like 20 rupture cases, but there's a follow-up data shows not that good result. However, we don't have any rebleeding cases, but the rupture case, no, we don't put the antiplatelet, no.
Okay. So it's for unruptured cases?
Yes, exactly.
And you talk about oversizing.
Yes.
So, for example, we have an aneurysm where the length is, say, 5 and the width is 4, where you typically would be using 3 into 4 mm web, So when you oversize it, how do you ensure that the web stays within the aneurysm?
Yeah, I think it depends on the morphology of the aneurysm. The morphology is very important. When you're sizing, you are not just see the lateral sizing. Morphology is very important. But I have a more focus on the lateral compression. So even though the height, I don't get some like if size aneurysm size width is like a 6 and the height is the 6, maybe I'm gonna do like a 8/3. So I'm gonna focus more like a lateral compression. So it is not it is not to know what is oversizing, but because sometimes when I the measure the sizing or deciding the annual web, I have two web in my mind. One is the relative safe, one is relatively the oversizing. So initially I tried to get some more safe one, but recently if two web is in my mind, I'm starting with a little bit bigger one.
Okay. And do you use a balloon very often?
Not really, but I do use, but stent very often. Yes.
Oh, so you stent them.
Yeah, but and I think the problem is when you see, I spend more time to get some cone beam CT after procedure, but when you see the 2D, it looks very good. But when you see the rotation angio and cone beam CT, sometimes web is a little rotating, and then you can get some dog ear the other side, but easily not easy from the 2D image. So that's why then, actually this patient bound to recur over web compaction. So in that case, we have to adjust a little again, or we can oversizing. So that's very important. You have to spend some more time for post-assessment for the web.
So one last question, which you started your talk by saying that you thought web would be another device that would not last. So what's your take on the contour?
Actually, I think I don't have any experience contour, be honestly. But the problem is the beauty of the web is the sizing is very complicated, but we are able to protect the dome. But the problem contour is I think it's a nice concept, but I don't think we are able to protect the dome. So that's one of the drawback of the contour theoretically. But the beauty is looks like the sizing is more generous. So we see. I love to see.
Thank you so much.
I think, one sec, I'll just ask, Laurent, do you have anything to comment, to add to this? Piero? Because he has the registry, run the French registry on the web.
Thank you, Anil. Very nice presentation, and I share what you have said regarding, the sizing of the device, which is in my mind quite critical. I think there is another point which is in my mind more and more clear. I think I have treated more than 250 aneurysms with web as of now. So, but I started from the beginning in 2011. My impression is that it's very important to oversize in width. We don't care the height somewhere. We don't need to fulfill the fundus with the device, probably because we will have immediate thrombosis in the device. Another comment is I don't use the same antiplatelet regimen, which means I use premedication with dual antiplatelet therapy, singularly in case I have to use a stent, and I agree with you, I am not too much using balloon, but when I have a compromise of one branch, I will place a stent, and I agree with that. But if I am not using a stent in addition to the web, I will stop immediately the dual antiplatelet treatment. There is sometimes we can see a very specific situation where you still have contrast in the web after 6 months. And maybe, because it's not so clear, but maybe it's due to the fact that we have dual antiplatelet treatment, which is preventing intra-web thrombosis. So for me, I just use aspirin after the procedure, except if I have severe stenosis created by the web. In that case, I will continue with dual antiplatelet treatment, but otherwise I will stop. I use Relive, by the way, ticagrelor. So I will stop ticagrelor immediately after the procedure, and I will just continue for 1 month, 6 weeks with aspirin.
Totally agree. I thank you for the comment, but I have a little bit limited experience. That's why I think it doesn't hurt to to continue just during for 1 month. So until I have some more evidence, I totally agree with Dr. Pierret. Yeah, thank you very much for the comment.
Thank you, Leon.
We have to go to Pune now and then to Chennai.
Okay, so we'll just see the last. Yeah, Dr. Arulkar, you can just show us your last run and just explain it. Yeah. We can't hear you, Dr. Arulkar. We can't hear you.
This is which I showed you last. You can see on the native image, you can clearly see a waist here. I was not happy with that because I didn't want any surprises on a weekend. So I crossed with the wire again. It did cross with some difficulty. Then I used a short, very short balloon, 2.5 by 12 millimeters balloon, coronary balloon. The balloon initially got stuck for a few seconds at the proximal part of the stent. But after some manipulation of the wire changing its direction, it did cross. So a very gentle angioplasty was done. You can see the waist here. You can see the waist is gone. Right?
So how much pressure did you use at this time?
This was at just 5 atmospheres.
Very interesting. That with a long balloon you couldn't get that, and with a short one.
So I did a close dilation at the edge also, the proximal edge also, since the balloon got stuck there for a few seconds. I didn't want a desperate has been raised when it was on this later. So a close dilation in the proximal part of the stent also. And this is the final picture.
What balloon was this? Length and diameter.
Pardon?
What was the length and diameter of the balloon?
Balloon was 2.5 by 12.
What by 12?
As usual, we took check shoots for 25 minutes after the balloon also.
No, Dr. Arulkar, what was the diameter of the balloon, you said? What was the diameter of the balloon?
2.5.
2.5, fine. And your original stent was, I thought, 2.25, isn't it?
Yeah, stent was 2.25 at 28. But being a short balloon, I was not worried much about the diameter because it was balloon, it was totally within the stent. So I was not worried about the size per se. I wanted a good dilatation of the.
I mean, you got a perfect result.
Check shoots for 25 minutes are not showing any problems. So the patient is already being exposed.
So what is important is he didn't go over the pressure. He just went to, you said 4 or 5 atmospheres.
He
Five.
I used to under
What
pressure,
was the
but
nominal pressure of that balloon?
Must
the
have been
nominal
8.
pressure of the stent as well as the balloon was 8 mm.
8.
For the stent, I stopped at 6.5 atmospheres.
Yeah.
And for the balloon, I stopped at 5.5 atmospheres.
So many times it is important not to try to go for full normal artery with that stent balloon. Better to go with a smaller balloon, it's safer to go with a smaller balloon. And not to go to nominal pressure, just enough to open that stenosis or open the stent. Cardiologists insist that no, the stent has to be absolutely well opposed, and we don't do that because as Dr. Matthew said, there is no internal elastic lamina or it is very thin and a rupture is very easy. So especially when we started, the literature was full of articles where when the stent was deployed, the artery tore. So we have therefore been always very careful with our inflation.
So thank you,
I
Arulkar.
realized lower than the size of the standard balloon, it is the speed of inflation which matters. If you are adequately slow and deliberate, then slight oversizing also is not an issue.
You have to be very slow with inflation. That is important. I do one more step. When we are taking the balloon out, we go in a little more and then take it out. Because if it sometimes, occasionally we've had trouble, when the balloon deflates, it gets stuck on one of the struts. So we just give a little tug inside and then take it out. And we leave the wire inside. Anand, if you notice, had taken the wire out with the balloon and with the brought the guiding catheter down. So if you have to go back in, it becomes a problem. He managed to get back in, but sometimes it can be difficult. So we usually leave the wire in whilst we are waiting for about 30 minutes or whatever time we wait. And that's what we usually do.
I used to do that, keeping the wire in during the check shoots, but I've changed in the last 2 years because I realized the wire changes the anatomy. It can act as a source of thrombus itself, and it can really sometimes come in the way of visualizing a small thrombus.
Okay.
So I always remove the wire and then take the check shoots.
So, Dr. Arulkar, thanks so much. Beautiful demonstration. I think not many people have done the post-dilatation, honestly. They have just accepted that 30%. That just shows your experience and expertise on this segment. So once again, thank you so much, and a big applause from all of us for a beautiful demonstration.
Thank you.
We quickly move over to Hyderabad. They have also finished their course. I mean, to Chennai, Srini's place. He just completed his case too. Dr. Srinivasan, are you done with your case?
Yes, we are done with the case.
Yeah.
We will just run you through what we have done. Okay.
So you were able to close it with coils alone?
Coils, and then in the end, I used about three coils, and then we've four coils, and then we have put a little squid just to seal it off.
Yeah.
This is the first coil. Can you see my screen, please?
Yeah, we can see.
Yeah, this is the first coil we have placed, and then I'll just run you through. This was the run right after. And this is the second coil. This was the run after. You can see it slowing down. Third coil. And this is the run after. Still slower. This is after we injected the squid. A little bit of, I just injected about 0.5 cc. I just placed it right there and injected. And in the intercavernous sinus predominantly. Some reflux into the left cavernous sinus, which was quite non-functional, so it was not an issue. Yeah, this was the run at the end of embolization. The right side, I have the control angiogram at the common carotid because she had supply from both internal as well as external. So this was a common carotid injection.
Yeah, that's a perfect job, nothing filling. I'm sure you got a very happy patient at the end of this. 2 days from now, she would be totally asymptomatic. Let's give a big hand to Dr. Srini also from this thing. Thanks so much for demonstrating this case this morning. Thank you very much.
You're welcome, sir. Thank you. It's my pleasure. Thanks, Gaurav. And I would like to show my team.
Yeah, please. We can see you with the mask.
Yeah.
Thank you, Sri. Thank you so much. Thanks a lot.
Hello. Thank you so much. This is Dr. Khanna, my junior consultant. Anbarasi, our cath lab technician. And Anusha, our OT technician, because we had to do the cut down. We brought her in, and she was all up front, bringing all the instruments to the cath lab. There are quite a few procedures we do in the cath lab also, like, typical EVDs and other things. For subarachnoid hemorrhage, we put EVDs here, do the angiogram and go. So in that way, they are tuned to this place. Our anesthetist, Dr. Babu Arnagri, Okay, from all of us, thank you so much. Thanks for the opportunity.
Thank you. Bye-bye.
Bye.
Thank
Well,
you.
that was quite an interesting session. Can we have a round of applause for our moderators and panelists who very diligently curated the entire flow of the session. Just a few important announcements for all of you. At exact 10:30 a.m., we have two flash workshops happening. One is happening at Inspire MD booth S4, and the second one is happening at Phoenix Tech Suite Studio 5. So if you would like to go ahead and participate, you're most welcome. In the meantime, I would request some moderators and panelists to step forward for a group photo op together. And I would request you all to please give them a round of applause for curating the entire session so wonderfully. Moving forward towards our next session, which is going to be quite interesting indeed, I would request the humble presence of our moderator, sir, here, Dr. Anshu Mahajan. Welcome, sir, with a round of applause, please. Followed by our panelists henceforth, Lauren Perrott, Thomas Liebig, Osama Zedat, Yong Sam Shin, and last but not the least, Sunanda Anand. Let's welcome our panelists here on the stage. Now, as we commence forward our next session. Please come. And I would request the moderator to take the lead on this. Thank you.
SMS Jaipur. Live transmission from SMS Jaipur. Rashmi. So we are going to have a first live transmission from Mumbai. Dr. Rashmi is doing the procedure. So can we have a brief discussion of the case?
So we're gonna go to KEM Mumbai to Dr. Rashmi Saraf, and this is a 44-year-old male who had a subarachnoid hemorrhage in January this year. There was an MCA, bifurcation aneurysm, which was considered to be the source of the bleed, and using a balloon assist coil, it was secured. That's the final picture at that time. So on the follow-up, and you can also see there's an ACOM aneurysm, reasonably wide neck, inferiorly pointing, anterior-inferiorly pointing ACOM aneurysm. So the plan today, I think, is to treat both the aneurysm. There is some recanalization in the previously treated MCA and the untreated ACOM aneurysm. So we go over to KEM Mumbai to Dr. Rashmi Saraf.
Okay, I cannot hear you all.
Hi, good morning. Dr. Rashmi, this is Dr. Anshu.
Yeah, hi Anshu. So we are already there. Our Sophia is in the ICF. We are taking our VR catheter into the ACOM aneurysm. And our plan is to put a web device for the anterior communicating artery aneurysm. We have already done the measurements. So once we negotiate the catheter, we'll start the deployment of the web.
What size have you planned?
So we have decided about 5 by 3. After taking the average of the maximum width of aneurysm and height of the aneurysm, 5 by 3 is what we have decided.
Okay.
So let's take a roadmap. Take a shoot from me. Yes. So we have taken a pre-shaped via 90 degrees since the angle of the aneurysm is quite medial. So we'll see how comfortable it is. If we can position that, we will do that. Otherwise, we'll take a normal via. Straight.
So we had an audience poll. So how will you prefer to treat this ACOM aneurysm? So, intrasacral device, FD, stent
Let's
plus
take a
coil
roadmap simultaneously.
surgery. Or you can also plan balloon assisted coiling.
Live. Should we? Should. Okay, good. Sure. Give the roadmap where maximum aneurysm is seen.
Dr. Rashmi, have you shaped the microcatheter?
Yeah, so it's a pre-shaped 90-degree microcatheter because aneurysm is quite medial. So we want the catheter to be stable. As we know, it's a midline aneurysm. So we are having blood, since Sophia is high up, now we are getting dilution from the left side. So we are taking a simultaneous roadmap from the left as well as right. Sure. Yeah.
It doesn't can take jump, so I don't know. Yeah. Okay, you can put the microphone all the way up and then, yeah, exactly.
The A1 angle is quite bad.
Yeah. Okay.
Yeah, she did.
So now it has taken its shape, and we can just slide the micro little bit in. So it stretches the AC a little bit, but if it takes the shape, it is quite stable for these medial. Okay. So we'll go a little in, and during deployment, we'll take it behind. Okay. Good monitor. Reduce the light of the lamp. Fluoro on. Fluoro on. जी प्लेन में एक अहेड जा सकते हैं क्या? रोडमैप लूज नहीं होना चाहिए, रोडमैप नहीं आएगा. This was our best angle in which we were planning to work. Let's prepare the well. Can we bring the camera
Can
here?
you show the preparation part? Dr. Rashmi, can you show the...
Yeah, we'll show the preparation. Can you bring the camera here? So we'll hold the sheet into the saline in this bowl. Can you show it in the bowl, inside the bowl?
We are not able to see that.
Can you focus here in the bowl? Just give a minute. Is it better visible?
Yes, yes.
Top se lena, upar se. Can you see the device?
Yes. Yes.
So we are now going to push the device out. We just see the opening of the device and we retrieve it back. Oops. So once it is retrieved back into this sheath, we will take it and we'll into the Y connector.
So this maneuver is done to remove the trap air.
in the
Yeah,
device.
and just to see the opening of the device. Moreover, to see the opening of the device. Otherwise, you can even take directly and backflash from here. Lights here. We'll still do backflash here.
So normally,
Most of the microvention devices, they prefer opening them in the saline just to see the devices opening well.
Can I have one comment? So actually, the via catheter is relatively stiff compared to the other microcatheters. So normally, once you put the via, I recommend have another roadmap because the via may change the angle.
We will take another roadmap.
And what's
because the direction changes.
What size web you are using?
5x3 web is what we have chosen.
5x3. She didn't inform us about what is the size.
We'll take a shoot. Sunny. Then we'll take a good night. Sure. Yeah, please. Leave and show. Yes. So come back. Check your light something. Come back. Okay, go ahead. Okay, ahead. Keep this in A plane. Next time we should see the movement is left. B plane, come back. Keep the patient deep now. So let's go. So on. Lights come down.
So you park Sophia in all these cases in high up in the ICU?
As far as it can come, it is always more comfortable. This is deployed. Looks okay to me. We'll take a shoot. Light here. Next position. So close. There it is. We can already see there is marked stasis.
Yes. Excellent deployment.
Go ahead.
So we saw that the via catheter was quite stable while you were
Yeah,
tracking the
the
device.
tree-shaped angle is helping because this is quite a medial angle.
Yes.
So we can see the device. Change to fluoro zoom.